Hello, my name is Debbie Jacobs. I'm faculty on the Cornea Service at Massachusetts Eye and Ear Infirmary and Associate Professor of Ophthalmology at Harvard Medical School. It's a pleasure to be invited to participate in Class 2020. My topic is options for clinical dry eye treatment. Dry eye patients show up in our offices with typical symptoms such as irritation, tearing, burning. They may have no signs, their eyes might be red, and typically we look for staining of the surface and superficial punctate keratopathy. The name for this collection of signs and symptoms has evolved over time. Early on, it was called keratoconjunctivitis sicca. In the 90s and early 2000s, folks started to call this dry eye syndrome. This later evolved to dry eye disease. In the last decade, we tend to refer to this as ocular surface disease and a dry eye subgroup within it. Who knows what the classification symptom will be in the future? In 2007, the International Dry Eye Workshop published this schematic showing that in dry eye disease, here, it can be broken down into aqueous deficient and evaporative dry eye, and then there's everything else called non-dry eye disease. As I said, our understanding has become more sophisticated. We now know that it's not just about tears, that the ocular surface, in addition to the lacrimal gland and tear film, has cornea, conjunctiva, and lid margins, and it's a fully integrated unit as great importance to vision and health. Furthermore, that the structures at the ocular surface don't stand alone. They indeed are part of the integrated lacrimal functional unit, which includes nerves that arise at the ocular surface and extend back through the trigeminal ganglion to the brainstem, and then other nerves that in turn innervate the lacrimal gland and other adnexa in the lids. From 2007 to 2017, the schematic got more complicated. You start with a presenting patient who may or may not have symptoms. For this group, I'm going to assume that we have a symptomatic patient. After all, that's why they're coming to you. And then we break this down into whether or not there are signs. If there are no signs, we have to think about whether they're in a preclinical state or whether they have a pain syndrome, which is beyond the scope of this talk. Instead, we'll focus on those who are symptomatic, who do have signs, and then we go right down through this algorithm to dry eye disease, where we determine if it's aqueous deficient, mixed, or evaporative, and then we manage to restore homeostasis. Dry eye disease has high prevalence. If clinically diagnosed or by survey asking about dryness and irritation constantly or often, it was found that nearly 6% of American women under the age of 50 have dry eye disease, but that amount nearly doubles as we pass age 75. Among U.S. men under age 55, the prevalence is quite low, but over 80, it approaches the prevalence seen in women. This high prevalence is very important from a market impact perspective. Topical cyclosporin A was FDA approved here in the U.S. in 2003. U.S. sales in 2008 were $444 million. It was the first and only treatment for chronic dry eye until Xiidra entered the market in 2016. It is my own impression that these two agents are very helpful only in a minority of cases. Dry eye disease is the fastest growing ophthalmic pharmaceutical category with 10% growth per annum and 1.7 billion sales in 2009. There's a broad spectrum of disease in dry eye. On the left, you see what's a typical patient, a 45-year-old with rosacea, and he has symptoms that are substantially greater than the signs. In the middle is a patient with GVHD, and you can see that in such cases, the signs are commensurate with the symptoms. The signs of filamentary keratitis are shown below. On the right is a 68-year-old with Sjogren's. In this condition, there's often very few symptoms, but a lot of signs, and this is in keeping with the neuropathy that accompanies Sjogren's. Nichols, and Mitchell reported in 2004 the lack of association between signs and symptoms in patients with dry eye disease, and this makes management challenging, particularly for the vast majority of patients who present at the left-hand end of the spectrum. The clinical metrics most commonly used for dry eye disease are the Schirmer test, shown on the right, which can be done with or without anesthetic, and vital dye staining. For vital dye staining, we can use fluorescein, rose bengal, or lissamine green, which each give us different clues. There's the clinical rating system below, or we can use more quantitative ones, such as NIH, Oxford, and Ben Westerveld, that are all very helpful for research. Also, with the help of vital dye, we can quantify tear breakup time. There are other metrics that have gained increasing attention in the last decade. These are surveys such as the OSDI and the NEI-VFQ. Tear osmolarity can be used, tear MMP levels, and impression cytology. Finally, confocal microscopy can give us clues as to the state of the epithelium and the corneal subbasal nerve plexus. For the treatment of dry eye disease, I'm going to refer back to the 2017 TFOS DUES 2 report, which has recommendations for the staged management and treatment of dry eye disease. This is a busy slide, but we will go through these in their individual steps. Step 1 for mild disease includes the following: education regarding the condition, its management, treatment, and prognosis. Patients are typically relieved to hear that this is typically not blinding disease. We can work with them as to modification of the local environment and provide education as potential dietary modifications. We can eliminate offending systemic and topical medications, and then we can recommend ocular lubricants of various types. We can also recommend lid hygiene and warm compresses of various types. As far as ocular lubricant, there are myriad drops, gels, and ointments on the market. I recommend that the patients sample many and choose what gives them the most relief or is the least expensive. As far as selection between drops, gels, and ointments, I'd like to emphasize that gels and ointments are not the same thing. Gels, like drops, are water-based and have a relatively short dwell time on the ocular surface. Ointments are petrolatum-based and have a much longer dwell time and superior barrier function. If step 1 options are inadequate, then we move to step 2, therapeutic interventions for dry eye. These include preservative-free lubricant agents, tea tree oil if there's Demodex, tear conservation in the form of punctual occlusion and moisture chamber spectacles or goggles, overnight treatments such as ointment and moisture chamber devices, and then various in-office treatments dealing with the meibomium glands and lids, and then prescription agents, drugs to manage dry eye disease. These are typically topical antibiotics or antibiotic steroid combinations, topical steroids, secretagogues, immunomodulatory drugs, and then oral agents such as macrolide or tetracycline antibiotics. Of the step 2 options, I'd like to spend some time on punctual occlusion because I feel pretty strongly that this is underappreciated. Often I'll hear from patients that they tried plugs, they didn't work, or doctors will say they're not worth the trouble. But I think that this is an art and these do benefit most patients. I strongly recommend a trial run of dissolving plugs. It's in this way that the patient can assess whether they offer relief. We don't expect total relief. What we expect is reduction of symptoms and particularly reduced dependence on lubricant drops. Of the dissolving plugs, there are 2 types, collagen, which lasts days, and polyglycol, which lasts months. I choose polyglycol these days because it's been my experience over decades that maybe 1 in 10 patients has a hypersensitivity reaction to the collagen plugs, which are made from purified animal product, whereas the polyglycol plugs are synthetic and don't tend to cause allergy. To the right, you can see the insertion technique. You grab them with a jeweler's forceps. I use a drop of anesthetic first, then I put them into the ampulla perpendicularly, then I let go, turn the lid outward in on stretch, and with a closed jeweler's tap the top of the plug, pushing it further into the ampulla, and then with the lid on stretch, push it around the bend. This is easy for the lower lids, not so easy for the upper, but this results in good placement of the plug. I place all 4 for the trial run. I bring the patient back at 2 weeks so I can assess how they're doing as far as symptoms and reduced drop dependence. I tell them to expect the benefit to wear off over the next 2 months, and then I bring them back about 2 months later. If they report that there was benefit that dissipated, then I say, well, then we can go to a more permanent occlusion. If they're not sure, we do a trial run. When I do, again, if I do go to permanent occlusion with silicone plugs, I tend to do the lowers only because these offer more complete occlusion. I size based on eye and then based on ease with which they are put in and come out with retraction on the stylet. If they pop in too easily, when I tell back, if I pull back out and they come out, then I switch to a larger size. I want them to push in with some effort and then stay in as I start to pull back. If they come out, then we go to the next size up, and so on. Among step 2 options for dry eye are moisture chamber spectacles or goggles. These, in my opinion, are underappreciated and underutilized. And the lower left shows someone using moisture chamber goggles. These are expensive ones sold by 7eye. They come in both tinted and non-tinted versions, so you can get clear ones. They have some that look more like designer Chanel glasses instead of biking glasses, so they're quite fashionable. And they can have refractive correction put into them up to about 4 diopters of myopia and a few diopters of astigmatism. 7eye is not the only brand. There are others which are listed, Wiley-X, and Onion Goggles is an inexpensive brand you can find on the internet. There is a brand that are nighttime occluders called Tranquilize, and those are shown on the right, that are moisture chambers that can be used at bedtime. Of course, they don't allow for vision, but patients find them very beneficial, particularly those with any symptoms that are worse upon awakening. If the step 2 options, and particularly punctual occlusion and goggles, are not effective, then it's reasonable to move into the step 3 options. These are oral secretagogues, which I don't find particularly helpful. Autologous or allogeneic serum tears and other blood products, which can be very helpful, but can be difficult to access, and then therapeutic lens options, which include soft bandage lenses and rigid scleral lenses. These are particularly helpful in patients with underlying disease such as graft versus host disease and Stevens-Johnson syndrome. As far as therapeutic contact lens, which is of particular interest to me, my recommendation for bandage soft lens is that you use a cosmetic lens with therapeutic indications. In the US, these are all silicone hydrogel lenses. Sometimes we have to go to a large diameter lens. The only one available in the US is the contour lens, which is a hydrogel. And the advantage of larger diameter for retention has to be weighed against the disadvantage of low decay. Some eyes are too dry to retain therapeutic lens. They fall out or are uncomfortable. There's a separate issue of prophylactic antibiotics, as all these patients are at higher risk of infection if they are using the lens on an overnight basis. Another good option is Rgp Scleral Lenses. These are used on a daily wear only basis. There is lower risk of infection because of the Rgp material and the daily wear basis. There are numerous brands out there. I've not listed them all. They include Jupiter, Europa, SoClear, MSD, Maxim, Boston Sight, Scleral. With these various options, it still may not be possible to fit all eyes, and one needs a specialty fitter who is willing to take on the challenges of fitting these lenses and fitting them in symptomatic patients. When commercial scleral lenses fail, there are more customized options, including Pro's treatment and iPrint Pro, which may allow fitting of a more unusually shaped eye. There are still issues to address as far as tolerance in the patients who require these interventions. If step 3 options are insufficient, then DEWS 2 recommends moving to these step 4 options. The first is topical steroid use for longer duration. In this instance, I recommend consideration of the soft steroids that are more likely to be IOP sparing. I also feel quite strongly that if a little is effective, it does not mean more is more effective, and often it is possible to find very low dose, such as 2 times weekly use, that is just enough to relieve patients' signs and symptoms. One can move to amniotic membrane grafting. AMG comes in various forms, including the frozen form depicted in the second image. This is applied with either sutures or fibrin glue. There is a freeze-dried form that can be applied under a bandage contact lens and is probably the easiest to use and the most comfortable for patients. And then there are self-retaining forms of amniotic membrane in which the membrane is adherent to a ring that is placed in the eye, much like a therapeutic contact lens, for a number of days. One can move also to surgical punctual occlusion. I have a lower threshold to move to this if permanent plugs fall out or are irritating, and if trial of dissolving plugs shows benefit. Finally, there are other surgical approaches such as tarsorrhaphy and salivary gland transplantation. For the remainder of this presentation, I'd like to talk about my own personal treatment strategies. I like to call these my clinical pearls. So in my approach to the dry eye patient, I believe that all treatments are additive, that none are exclusive, but that must choose to do one thing at a time. Furthermore, I believe that it's important to let the patient choose what we're going to do in what order. This, of course, takes time. We need to explain to the patient what the options are and how they might help. I think it's important because if we simply do a lot of things in a rush to get the patient out, they are likely to be disappointed in the effect and be back. For that reason, I like to talk to patients about what the choices are, let them choose, and then when I bring them back, I believe very strongly that the only valid response is subjective. Of course, there's the exception in persistent epidefect in which the patient is at risk of infection and melting, and in that case, I do assess response based on the size of the defect as well as the patient's symptoms. So, for example, if I step up the treatment from from drops to gels, or if, for instance, I place dissolving plugs, when the patient returns, I'm going to ask them about comfort, vision, and redness, and I'm going to ask if each of these metrics is the same, better, or worse. And in that way, I can find out if we're making progress in their dry eye syndrome. Let me stress again that in my treatment approach to patients with ocular surface disease, and particularly those who have dry eye as their entering diagnosis, I believe that the only valid response is subjective. I believe that tier metrics such as Schirmer, staining, and OSMs are of uncertain value. I will say that I do use Schirmer test in my first encounter to assess how aqueous deficient the patient is. That is a justification for moving forward later with permanent punctual occlusion. But I do not use Schirmer to assess response to treatment. I do use staining as a correlate to what the patient tells me as far as their discomfort and whether it's same, better, or worse. And if the staining change matches their subjective response, I feel more confident in moving forward based on what their response is. This is a very patient-centered approach, which is quite different from the way that most of us are used to practicing. But it's my experience that with dry eye, if you don't address the patient, you will not address the problem. This is in keeping with the report by Nichols, and Mitchell that I mentioned earlier, that generally there's a lack of association between signs and symptoms. I like to focus on the symptoms. In this regard, I have published with colleagues Fong and Motajedi a new patient-centered approach to ocular surface discomfort that describes a way of looking at these patients. This is a figure from my publication with Mojahedi and Fong on this new patient-centered approach to ocular surface discomfort. It's a busy slide and you can see it in more detail if you go to the publication. In any case, I focus first on the primary complaint, and you'll see that dry eye doesn't appear there. When I see a patient who is referred or complains of dry eye, I tell them that I don't accept that as a diagnosis, and I ask them to talk to me about their symptoms. And depending on whether the primary complaint is intermittent blurred vision, gritty sandy sensation, burning, itching, tearing, or contact lens discomfort, I proceed differently according to the algorithm. Basically, depending on the primary complaint, we look for what the underlying process leading to that complaint might be, and then we undertake initial treatment that is either ocular or non-ocular. I find this more useful than approaching this as dry eye per se. Again, I find out if the problem is intermittent blurry vision, gritty or sandy sensation, burning, itching, tearing, or contact lens discomfort. Each of these are labeled by other doctors as dry eye, but I tell patients that I don't accept that as the diagnosis.
Hello, everybody. My name is Jason Nichols, and I'm the program chair for the Global Specialty Lens Symposium and our new meeting, the Global Myopia Symposium. We look forward to bringing you cutting-edge information each year, and again, we look forward to hosting you in 2021. Thanks, everybody.
Here are more details of my actual preferences in the treatment of dry eye syndrome and ocular surface disease. As always, I'm guided by symptoms more than signs. As far as lubricants, I advise that the patients try many and ultimately suggest that they choose the one that costs the least or stings the least. If they find they're using it more than 4 times daily, then I advise that they should go to preservative-free formulations. If there are filaments or geographic epidefects, then I strongly recommend ointment, which can be used at bedtime at least, and more often during the day if they don't mind blur or to heal a geographic epidefect. If lubricants are helpful, I move very quickly to punctual occlusion, because I think that's the way to get a longer duration benefit. I also find that many patients are on systemic antihistamines. I ask where their allergy symptoms are, and if they put their hands up to their mid-face and eyes, then I push them to use nasal steroid instead. In seeing patients that have dry eye syndrome, it is also important to consider that they may indeed have medicamentosa. They may be having problems at the ocular surface from aminoglycoside toxicities. The glaucoma drugs can be bad boys as far as ocular surface disease. One must consider whether they are on prostaglandin analogs, adrenergics, or topical carbonic anhydrase inhibitors. Try to minimize these with combo drops, or consider switching them to drugs in the same category that are preservative-free. That is, it's very important to reduce the preservative load among all the things they're taking, and also to consider that some of the glaucoma meds have direct action on the ocular surface separate from any toxicity issue. It's also important to consider that what may be causing their symptoms of dry eye syndrome may in fact be a broader ocular surface disease in the form of exposure or lid dysfunction, and that none of the dry eye symptoms will get better unless the lid dysfunction or exposure is recognized and addressed. More preferences as we move up the ladder in the treatment of dry eye syndrome. I do consider soft steroids, cyclosporin A or lifitegrast, if there's underlying autoimmune disease, moderate to severe allergy, or if there's atopy, and for rosacea. For rosacea, I also consider doxycycline or metrogel. Regarding the steroid, the soft forms are loteprednol and fluorometholone. I think it's important to take advantage of the steroid of their IOP sparing effect. I'm a big fan of the ointment form at bedtime because these have depot and barrier effects that can be beneficial. Another teaching point on the steroid is just because some is good, more is not better. 2 times a day is the maximum needed for disease limited to the ocular surface. My approach is to reduce to 1 time a day and then Monday, Wednesday, Friday over weeks to months. I typically monitor the pressure every 1 to 2 months initially, and then every 6 months for those requiring long-term suppressive treatment with soft steroid. Some of my preferences for punctual occlusion in the treatment of dry eye syndrome. I'm a big fan of a trial of polymer occlusion in all 4 plugs, and seeing the patient back initially, and then if there's benefit at 6 to 12 weeks, at which time I put in silicone plugs in the lower only. If the patient is uncertain whether punctal occlusion helped, I do a repeat trial. I also encourage caution with mucosal punctate, which are more common than you think, or in patients with East Asian lid configuration, because the lids will turn inward with blink and they may feel the cap of the plug. In patients with mucosal punctate or East Asian lid configuration, you may need a plug with a flatter cap, or cautery may be your best choice. If you do lower occlusion with benefit and the patient is still symptomatic, I do recommend a repeat trial of polymer plugs again before considering permanent occlusion of the uppers. Again, the patient must be clear in what the benefit is, and then they will not be disappointed if the benefit is not achieved when you do punctal occlusion. This approach is time-consuming, but more likely to result in a happy patient. In conclusion to the CLASS 2020 options for clinical dry eye treatment, this is my take-home message. Don't treat dry eye. Treat dry eye syndrome. The symptoms are the target, not the signs. Treat the symptoms of the underlying ocular surface. In closing, I'd like to thank you for your attention. Gracias. Obrigado.